just talk briefly about that. So let me share my screen. All right, open up my chat, move you guys over here and over here. All right, so you should all be able to see the screen here, and it looks like your Blackboard for your assignment this week. Everybody able to see that? Yep, perfect. Thank you. All right, so this one, again, it's going back to an APA format. So I want to clear up a few things with that. One, let's just go over the scenario quickly. So you're a night shift med-surg unit. You get a 19-year-old who's admitted early in the morning. She's got 30% burns over her body surface area with partial thickness burns on her legs and back. That is not in addition to the 30%. That is part of the 30%. It's just kind of an added piece of information. The key number here is the 30% BSA. So the instruction to this, ignore this. If you can do it in one page, I'm happy you can do it in one page. As long as you follow APA formats, and just discuss the following. So it's the Parkland formula. And we'll go over that in today's lecture just to underscore that. But, you know, what's the fluid resuscitation? So you're going to do the Parkland formula. So again, she arrives at 2 a.m. is the injury time. You get her at 4 a.m. She weighs 110 pounds. There's the other really important number that you need for the Parkland formula. You need the BSA and you need the weight. And you're going to convert that, though. Convert that to kilograms. So you divide that by 2.2. That gives you your keys. And then the Parkland formula, the other magic number that's a constant is 4 milliliters. So you multiply that. You multiply 30 times 50 kilograms times 4. And that gives you the amount of fluid that that patient is going to get in a 24-hour period. And we'll underscore that in the lecture a little bit later. So then you have to explain the time intervals. And the way the Parkland formula works is you get that number, let's say arbitrarily at 6,000. 6,000 milliliters of fluid, and you divide it in half. So 3,000 and 3,000. The first 8 hours, that patient gets 3,000 milliliters of fluid. But if you're not starting this until the patient's 2 hours post-injury, it's time of injury. So that fluid rate is going to go from you lost 2 hours, so it's going to go in under 6 hours. So, but it's the first 8 hours they have to get that fluid. And if you don't start the fluid therapy for 2 hours in, you have to speed up the rate. The second half of the fluid goes in over the next 16 hours. So that's what you divide that by, and that's how you get your drip rate on that. The other thing you need to address is that she was sleeping when the fire started. She made her way out of the house through thick smoke. So what are your concerns about smoke inhalation? Just give a little discussion about that. What assessment findings corroborate that concern? Clients in severe pain. What a couple of drugs of choice you're going to do and why and how should they be given? The nutritional requirements necessary and how are you going to prevent infection? Again, so it's an APA paper, so anything that you insert here in text and it's fact, cite it in text citation. Have to have a reference page, and easy to just to section it off, these different headings, and then you can just give a blurb on there. Again, I don't count words, I don't count pages. If you can give all of this information succinctly, have at it. As long as you follow APA format and you get a reference page and a cover page, I'm happy. If you're unaware, there is an APA template available, which you just kind of plug and play. If you do not have that, let me know. I'll email it to you. Any questions about this week's assignment? If any questions come up, feel free to shoot me an email, and we'll talk you through it. And as always with these assignments, if I notice something that's deficient, I'll give you the opportunity to correct it before I grade it. So if I see an APA issue, I'll let you know what the APA issue is and how to correct it, and give you the opportunity to resubmit before I grade. Is that a deal with everyone? As long as you put in the work, I'm happy to redo the work, and it's your choice. If you don't want to correct it, that's fine too. Some people choose not to. But that is the scoop with this week's assignment. All right. And this week is obviously on burns. So that's what our lecture is. The lecture is going to run about an hour and maybe 20 minutes. It's not that long. It's 75. If you have any questions, feel free to ask. If you need me to slow down, tell me to slow down. And we'll break probably in about an hour. Give your butt a little break. And my philosophy is the mind can only absorb what the butt can endure, and that's usually about an hour. So let's get into it. Any questions before we get going? Awesome. All right, well, let's talk this week.
I'm sorry, Professor. I do have a question.
Sure.
This kind of goes back to what you were saying in the beginning of the class about our exam reviews. So would you send us a emailed video how many days before the actual exam?
I'm not sure yet. It'll be ample time for
Okay.
you. I'll try to get it up as soon as possible.
Okay.
Before the exam. Yeah, because it's in week 9. We're in week 6. I'll get it up Ideally, at least a week before.
Thank you.
Okay, sure. All right, I'm going to stop my video because nobody needs to see me. And WebEx Assistant. All right, cool. Well, let's go on. What are we going to go over this week in lecture? So we're going to go over the epidemiology of burns, the cause of burns, the different classifications, and it's based on depth, consequences of burns, how do we assess those patients, and then we're going to go over those 3 phases of burns and their interventions. And those phases are emergent, acute, and the rehabilitative phase. So let's talk about the epidemiology of burns. So 500,000 people a year are seen for burns. It's a lot. 40,000 of them require hospitalization, and of those 40,000, 60% of them are admitted to a specialized burn center. There's about 28 certified burn centers, and that has a special equipment. It has special personnel. It has to be accredited to be a burn center. And in our area, we have a couple. We're lucky. We have Tampa General, that's a burn center, and Blake is a burn center. Blake is a relatively new burn center down in Manatee County. And I believe Brandon Regional is in the process of getting their pediatric burn center credentialing. But they have to go through rigorous credentialing for that, and they have to have a lot of criteria to meet to be a burn center. Back in the 60s, if you had half your body burnt, it was fatal. You weren't going to survive that. Today, some people up to 90% can actually survive. It has to do with advancements in resuscitative burn care, improved wound management. That's a huge one, which couples in with infection control. And we treat inhalation injuries a little bit more aggressively. We have improved care of the hypermetabolic patient. We'll talk about all of these going through. It's the 5th leading cause of accidental death in the home, and burns from flame account for the most common of children greater than 6 years old. Males tend to be a little bit more than females. We are the risk takers predominantly. Sometimes we're not the smartest. Sometimes we have the hold my beer and watch this mentality. So we tend to get injured a little bit more often. Here's a chart that kind of goes over the different types of burns. So the first one we talk about are thermal burns. That's from external heat sources. That can be open flames and explosions for that dry heat, scalding, hot liquids or steam for the moist heat, and contact burns. That's just touching something that's really, really hot. Could be metal, tar, grease. We live in Florida. The sun is very hot here, so it's not uncommon to get a surface burn, a contact burn, touching some metal object outside. The good thing about these types of burns is they're generally confined to the area of contact. The extent of the burn depends on the temperature and the length of the contact. Don't forget about cold thermal. Now, we live in Florida. It's hot here, but a lot of you come from other northern, colder climates where the risk of frost nip and frostbite is there. And again, that is the same pathophysiologic manifestation like a burn. It's tissue damage, and the pathophysiology that contributes to that is the same at that cellular level. Chemical burns we need to be cautious of, and that can be anything from strong acid, alkalis, phenols, phosphorus, petroleum products such as gas and paint thinners. And the severity is really related to what the chemical is, first off, the concentration of it, length of exposure. If you have any damage to the skin, underlying tissues, that can occur over several hours, sometimes days, depending on what that caustic agent is. One of the real key concepts when it comes to chemicals is that if it's dry, you brush it away first. You really want to get those powders away, protect yourself with personal protective equipment, and make sure that they're all that dry powders away before you copiously irrigate them with water for about 20 minutes, sometimes up to 2 hours, depending on what the offending agent is. Radiation, the simpler forms, is just UV light, sunburns, and that's usually confined to the area of contact and depends on the temperature and the length of contact. We live in beautiful sunny Florida, and we see a lot of, say, Eastern European with very pale skin come, and they spend a day or two in the sun in clear water, and they look red as a beet. So, that's a UV light radiation sunburn. Then there's non-solar radiation. Those are alpha, beta, and gamma sources, and that really just depends on the source of that radiation. The length of time is a real big indicator, and that can be acute, chronic, and you can have latent effects. And in the medical community, we as nurses can actually work in environments where we're exposed to this non-solar radiation frequently. That is interventional radiology, it's cardiac catheterization lab. So we protect our staff, our nursing staff, physician staff, and tech staff with lead aprons, lead thyroid shields, lead hats, and we even have leaded glasses. You can see through them, but the lead prevents that radiation from penetrating the retina. And finally, we have electrical burns. Electrical current passes through the body, and these things can be very devastating. It's usually extensive deep tissue damage to the muscles, nerves, soft tissue, sometimes organs. Again, it generates a lot of heat going through there. The damage does depend on the current, the length of the contact, and these patients have a tremendously high risk of cardiac arrhythmias, respiratory arrest. They can get severe metabolic acidosis and myoglobinuria because of all of that muscle destruction spills all that myoglobin into the blood and then through the kidneys, and they can get significant kidney damage. And depending on the path of the electrical arc, it can result in significant internal injuries, and it leaves little evidence sometimes of the external contact. I've had taken care of patients who have been electrocuted and have just tiny little entrance, a little bit bigger exit on the opposite side of the body, but total destruction throughout. So what are the consequences of burns? Well, smoke inhalation, respiratory injuries, that should be really high on our list of possible consequences. Fluid and electrolytes, and there's going to be a lot of derangements, initially from the pathology of burns, and then secondarily from the treatment of burns. There's going to be protein loss. And remember, protein's like a giant sponge. When you lose protein out of your vasculature, it pulls fluid with it. So we'd expect to see a lot of edema. There can be sepsis. Remember, skin is the largest organ of our body, and that organ does offer a huge amount of protection from outside pathogens. And if we disrupt it on a large scale, we do have a high risk for infection, and sepsis could follow. There's changes literally in every part of that body: metabolic, endocrine, respiratory, cardiac, hematologically, and in immune functions. And the extent, again, is related to, well, your age, general health, extent of the injury, depth of the injury, and the specific body area injured. So let's roll right into the true medical emergency of smoke inhalation. It's usually thermally produced, hot air, steam, or smoke. Mucosal burns of the oral pharynx and larynx are common, or mechanical obstruction can occur quickly, and that mechanical obstruction is due to edema. So damage to the respiratory tract, you get a major predictor of mortality in burn victims. So it needs to be treated quickly, and I can't underscore that enough. Hoarse, brassy voice, they may appear asymptomatic initially, but they develop respiratory distress, and it could be up to 36 hours after exposure, especially in fires. Produce these small particles with low water solubility. And think about it. If anybody's been in a campfire or a bonfire, and I know one of you was in last weekend, when that fire and that smoke is going up in the air, you see all those little bright pieces that are still burning. That particulate matter's in the air in a fire. So when you inhale that, that's going to cause some significant burns through that trachea. Historic risk factors for smoke inhalation: closed, confined spaces. The patient have that carbonaceous sputum. It's black when they cough it up. Elevated carbon monoxide levels and central facial burn. So this patient that you see in that picture down there, this person, if I were to fly in and land, I'm going to intubate this gentleman almost immediately, because the way he looks there, in about a minute and a half to 3 minutes, he can wind up being unintubatable. I don't know if that's a word, but I'm going to use that today, because of the amount of edema that's in there. So you want to consider chemical asphyxiants that might be there. That's carbon monoxide and hydrogen cyanide. Hydrogen cyanide is very prevalent in house fires because when you burn furniture burns, it releases that. A lot of those fibers and fabrics actually convert to cyanide. And there's other toxic substances that could be burning around, depending what's in the house. And we worry about inhalation injuries that are above the glottis, and there's inhalation injuries below the glottis, and the manifestation can be a little bit different. So this picture here is a patient. Again, if I saw this patient, I would immediately RSI and intubate this patient, because it's not a matter of if that airway is going to swell, it will swell. And I want you to kind of keep this picture in the back of your mind when we see a picture a little bit later on. So reliable clues to this injury are presence of facial burns, like this picture; singed nasal hairs, like this picture; hoarseness, painful swallowing. Again, that's edema, and there's irritations and burning and swelling around the vocal cords; darkened oral or nasal membranes, like this picture here. So pictographically, when we pick it apart with the upper airway and lower airway issues and what's causing them, so anything in the larynx there, that supraglottically, that hot air, hot steam, that's, again, it's going to hit that first. That's going to cause laryngeal obstruction, bronchospasm. The smoke and those hot particulates that we talked about get a little bit deeper into the trachea, and that causes mucosal sloughing, high risk of infection, bronchiolar plugging, atelectasis, and of course bronchospasm. And then way down deep are these irritant gases. That's going to cause pneumonias, pulmonary edema, and more importantly, these alveolar capillary defects, which you can see down there, is ARDS. Remember, that's a capillary alveolar membrane issue. You can have all the oxygen in the world, you're just not able to use it because it doesn't translate through that membrane. On the right there, these are indicators of need for intubation. The hoarseness, stridor, total burns. In this PowerPoint, again, something you can right-click and save for your notes and go over. So let's talk about carbon monoxide poisoning. It's produced by the incomplete combustion of burning materials. It's colorless, it's odorless, it's tasteless, which makes it very, very dangerous. An inhaled carbon monoxide, it binds with hemoglobin and displaces oxygen. Hemoglobin has a very, very high affinity for carbon monoxide. It takes it, it grabs it, and it holds onto it, and it refuses to let oxygen come on board. So they get hypoxia. They get carboxyhemoglobinemia, so they have a high CO level. And ultimately, if untreated, can presume to death. So the treatment is initially 100% oxygen, humidify if you can, but 100% oxygen. As soon as you put oxygen on them, it cuts the half-life of that carbon monoxide level. So it makes it less likely to cause damage. And in severe cases, depending on the level, we do hyperbaric oxygenation therapy. We force oxygen into those membranes, into the tissues. So we force it there hyperbarically, so until that carbon monoxide can run its course and be excreted out of the body. Carbon monoxide poisoning may occur in the absence of burn injuries. We hear about this in the wintertime, particularly in the colder areas, where maybe somebody's burning something in the house. Or in Florida, for example, during hurricanes, somebody has a generator running in the house or in the garage, and those fumes can cause carbon monoxide poisoning. The oxygen carrying capacity can be greatly reduced by carbon monoxide, even though the SpO2 reads normal. So you're going to put a pulse ox on these patients, it's going to be normal. Completely normal. It's 100% unreliable in the presence of a carbon monoxide poisoning patient. So they may be normal, but that patient is not getting oxygenated. So the skin color for these patients is that cherry red in appearance. There's a link here if you want to get a little bit more detail in carbon monoxide poisoning. But really just know that carbon monoxide is going to just stay on that hemoglobin until it runs its course. Oxygen, oxygen, oxygen for those patients. The second part of that is the hydrogen cyanide. So what cyanide does is it binds to the cytochrome C oxidase protein in the mitochondria. It limits the cell's ability to use oxygen. That's where the problem is. And it's commonly found in fire smoke because a lot of furniture burns creates the cyanide, and it should be considered with all smoke inhalations. So the treatment is we can give them hydroxycobalamin, which is a cyano kit. That's a relatively newer treatment modality. It's a one spike it intravenous dose, and you give it, and it's done. Prior to this, it was a different type of cyanide kit where you had to crush amyl nitrate capsules and have them inhale that. Then you gave them a two-step intravenous dose, but it had to be timed specifically, and it all started with the amyl nitrate. And the whole goal of that is it kind of deactivates the potency of what cyanide is and then allows it to be excreted. But now we just have this one and done, which is really wonderful. So let's talk a little bit about burn depth and assessments. So it's determined by temperature, time, thickness of the dermis, blood supply, early tissue damage at 104 degrees, and irreversible damage about 158. It's hot. So when we look at it, we have the superficial burns, or what we would classify as those first-degree burns. That's just the outer layer. You think of a sunburn, red and discolored. Skin remains intact, and that's the key differentiator there. About 2 to 3 days later, you get this desquamation of the skin. It sloughs off, it peels. And you see people sitting there peeling away. I worked with a girl who loved to peel sunburns. Gross. Getting a little bit worse, you have the superficial partial thickness. This is your second-degree burns. It's disruption of the upper third of the dermis. The wounds are pink, moist, and blanch, and the key thing is they blister. Very painful because the nerves are intact with this. But blistering is what makes a first degree become a second degree. And that can get a little bit deeper. You have deep partial thickness burns, and it's deeper into the dermis. The blisters typically do not form because the tissue's dead, so there's no need for that. There's deep dermal injury, which may need grafting, slow to blanch, or may not blanch at all, so the blood supply is compromised. And then, of course, you have your full thickness. That's entire destruction of the entire dermis, subcutaneous layer, muscle, bone, nerve damage. No pain. I don't want to confuse this that patient's not going to have pain. Again, these burns aren't in isolation. So that area may be third or completely full thickness burns all the way through, but there's usually surrounding varying levels surrounded by partial thickness, deep partial thickness. So there will be pain involved. The dermis is dry, it's contracted, it's rigid, it's leathery. It's called eschar. The color may be waxy white, brown, yellow, black. that charred skin with milky white areas. And that eschar is just all dead tissue, and it is hard. In these patients, you may not even be able to feel a pulse through that eschar. It requires removal of skin, grafting, destroyed tissues that can't regenerate. I'm going to tell you a quick story about the worst burn that I ever came in contact with. I was flying here in Florida, and a younger girl in her 20s, late 20s, her boyfriend wrapped her in a sheet, doused her in gasoline, and lit her on fire. She was found in the front lawn, awake, screaming. The fire department got there. They put her out. They stopped the burning process, called us. We landed. All of her fingers, all of her toes were burned off. She was contracted. She was 100% burned. She had thick eschar on every part of her body, and all she could do was kept saying, "Kill me, kill me." It's the only thing I could hear. I got a subclavian line in her, and I emptied every narcotic that I had in my pocket for that poor woman. We couldn't tell if she had a pulse. We couldn't tell if she had a blood pressure because that thick eschar prohibited us from doing anything. We intubated her, and we took her to Tampa General, and she ultimately quickly succumbed to her wounds, which were devastating. And even if she did survive that initial insult, there's no way that she was going to live for that. And that call stays with me because the eschar on that woman was so profoundly thick, and it reinforced, the need for comfort measures for these patients and to really advocate for those patients. But how do you assess those patients to see if they are alive or dead if you can't feel a pulse or can't get a blood pressure? They have actual special electrodes for these burn patients that actually have little corkscrews, and they screw it into the eschar, and then it can pick up some electrical activity of the heart. So remember, the skin is the largest organ of our body. It protects, it prevents water loss, and it regulates temperature. So when we have a burn like that, it loses the protection, where we lose that hydration, and our thermal regulation is gone. So we lose sweat and sebaceous glands and also sensory receptors. Let's talk a little bit about blisters, because that's the controversial thing with burns. The management of blisters is controversial because they can be left intact to facilitate comfort while underlying tissue heals. And if anybody's ever had a blister and it tears open, even wind makes that thing hurt. So you can imagine if it's a very large blister. On the other hand, it may obscure full-thickness wounds and need to be opened up to allow and facilitate healing. So again, there's no right or wrong answer with these. It depends on the individual patient. There's another large blister that would most likely be better left intact because that's going to be very tender underneath there. And another happy subject is burns from abuse. I'm saying that obviously completely not truthful on that. And usually from child abuse. It's common occurrences involving children 3 years of age and younger with either scald or contact burns. Socioeconomic status comes into play. Single parenthood comes into play. More than 2 children come into play, having a high incidence. And although it's not isolated to that. It can go all socioeconomic classes. One thing you need to know as a professional, and you will all be nurses, that you have a duty to report suspected child abuse. Sadly, this was one of my jobs when I was a young nurse in Connecticut in a trauma center. I was the pediatric sexual abuse nurse. And it was devastating to see a lot of these injuries that came in. And a lot of them look like this. So let's talk about these immersion injuries. They result from the child falling, okay? It can be accidental, or placed into a tub of hot liquid. So how do we differentiate if it's deliberate or not? The depth of the burn is uniform. Look at these pictures on the right. Look at that upper one. You can tell that is a dunking injury. The wound borders are very distinct, sharply defined. They're water lines, and a little tapering in depth of the edges. And usually, like this child here in the top picture, the next area I'm going to look at is the perineum, because as that child's feet get placed into this scalding water, they curl up and contract, but they're usually being held in place, so the buttocks and genitalia tend to go into the water instead of their legs coming out. Little evidence that the child was thrashing during the immersion. That's a lot of splash injuries you would see, so you don't see that, indicating that child's held in place. And occasionally there may be bruising of the soft tissue. Again, manhandled, for lack of a better term, abused secondarily too. Only children with deliberate immersion burns sustain these deep burns to the buttocks and genitalia and the anus. So those are all real hallmark telltale signs of abuse And you as nurses, if you come across this is definitely 100% reportable. Although we can't prevent that in the time, we can help gather the right evidence and prevent it from happening again to a different child. Here's a link for you that you can go in and really talks more about the nurses' roles and abuse and reporting. All right, let's talk about classification of burn injury and extent of burn injury. There's two commonly used guides to determine the total body surface area. One's the Lund-Browder chart, very specific. It's more accurate in the fact that it breaks it down into much smaller areas, so you calculate it to a more accurate BSA. More commonly is the rule of nines. The rule of nine is more common because it's adequate for the initial assessment of adult patients. So it's great. We can get a quick summation of the degree of body surface area that's burned, and then we can figure out the fluid resuscitation guidelines from it. So the rule of nines is much like lab values. There's some things that you can kind of learn through nursing and through experience, and some things you just have to memorize. And that's where this falls in. So the rule of nines here, it's the entire front and back torso is 18%. And again, when you look at that picture, think the upper part, 9%, lower part, 9%. Same on the back, 9 and 9. But the entire back is 18%. The leg, 18%. So if you have burns to just the front, it's 9%. Entire head, 9%. But if I have burns to just the face, 4.5%. So you it's 100% specific. There is some wiggle room there, and it is an approximation, but it's close enough to get us that early aggressive fluid resuscitation that patient needs. So again, if we take a scenario, and we'll walk through this, nobody's going to be doing quick math in the afternoon after lunch. So you have a patient involved in a car fire, received burns to his right arm, left anterior arm, anterior chest, and left front leg. So how do we calculate that? What's the BSA? Well, the entire right arm is 9%. The left anterior arm is 4.5%, because you figured it's about half of that. The anterior chest, the whole top, 9%, just the anterior chest on the top. The left anterior leg is 9%, because the whole leg is 18%. And when we calculate that total, it gives us 31.5%. So that's what we're going to base our fluid resuscitation guidelines on with the Parkland formula. And we spoke about that briefly, but we'll discuss it a little bit more in depth in a minute. Location of injury gives us clues. Face, neck, and chest, we worry about respiratory. Always worry about respiratory. Hands, feet, joints, and eyes, it's all about self-care. This patient's going to have a lot of problems down the line. Ear and nose, we worry about infection. Again, especially in the nasal passages there. We have all those hairs. We have turbinates that moisten and humidify the air, and all these physiologic and anatomical structures that help catch bacteria. If we destroy those, then we have a higher likelihood of that. Circumferential burns to the extremities, we worry about circulatory problems. We worry about compartment syndrome. We worry about that edema, swelling, compressing the nerves, compressing the arterial blood flow, and then we have no distal blood flow. And that's where an escharotomy comes in. We'll talk about that a little bit later. I even got a video to show you on that one. So when do we keep our patient? When do we send them to a burn center? So when you think about that, there's 138 credentialed burn centers. Most hospitals are not burn centers. So we need some criteria that give us a little guidance of when do we ship them out. So one, partial thickness burn, second degree, greater than 10% of the BSA. Yep, they're going to need some grafting. They're going to need some wound control, and they're probably going to start getting some fluid shifts. Any full thickness burn in any age group, they need to go to a burn center. Face, hands, feet, genitalia, perineum, our major joints are involved. They need to go to a burn center. They need the specialized care, they need the specialized equipment, and they need the specialized personnel to help preserve whatever function they can, because that's a functional impairment problem. Chemical and electrical burns, including lightning injuries, need to go. I unfortunately had brothers. They were swimming in a lake, a river actually it was, and lightning struck the water, and they both got electrocuted. They were both cardiac arrest. One of them got electrocuted was face up. The other was face down. When we got there, they were both alive. The face down was in significantly worse condition because he was also a secondary drowning patient. So, but both of them, we put a Foley in, dark red urine came out, myoglobinuria. So we took them to the trauma center and the burn center rather. So they were TGH versus a local trauma center. Any inhalation injuries have to go. And pre-existing medical disorders that can complicate the management, prolong recovery, or affect mortality. Any patients with burns and concomitant injuries and traumas, and multi-system trauma patients and burn patients. So they have two issues going on. And burn children in hospitals without qualified personnel or equipment to care for that child. That's important. Most children get flown out or ground transported to a pediatric burn center. And burn injuries in patients who require special social, emotional, or rehabilitative interventions. So what are our risk factors? What patients are more at risk for poor prognosis? So older patients, they just tend to heal slower. Pre-existing conditions, cardiovascular, respiratory, and renal disease, alcohol, drug abuse, and malnutrition are going to prevent that healing process, delay it. And any concurrent injuries, trauma, fractures, head injuries, etc. And of course, diabetes, contributes to really poor healing, and they tend to get gangrenous on that. All right, how's everybody doing? Okay? Am I going too fast? Good? All right, cool. If I'm going too fast, just tell me to slow down. All right, let's get into the 3 phases of burn management. That's the emergent phase, that's resuscitative, then the acute, wound healing, then a rehabilitative phase, which is just about restoration for those patients. So again, that emergent phase that we talk about, it's usually that 24 to 48 hours, that first, it can be up to 72 hours with fluid loss. So it's the period of time required to resolve the immediate problem resulting from the injury, whatever the initial insult was. It usually lasts sometimes up to 72 hours, but it begins with fluid loss and edema formation. Can't underscore that enough. It continues until the fluid mobilization and diuresis begin. So the goals is A, we always want to secure the airway. We want to support circulation. Pain management is going to be huge. Infection prevention is definitely huge. And we want to maintain that body temperature. Remember, we're losing all of this protection. So in the pre-hospital phase of it, we want to remove the person from the source, stop the burning process. It's very important. But in the same breath, we want to watch out for ourselves. You don't want to become part of the emergency. And those of you I've had in simulation or even just clinicals, I say this saying a lot. It's not your emergency. It's their emergency that you're a part of. So don't get too rambunctious to go in there where you get injured and then you can't help anybody. So be cognizant of your own safety. ABCs, definitely. We want to make sure that the airway is maintained, and early intubation, aggressive intubation may be necessary for facial burns and smoke inhalations. We want to get IVs on board, and it's better to get those IVs early because once that edema starts kicking in, it's going to be difficult to palpate the vasculature, let alone cannulate it. Dry sterile dressings if the burns are greater than 20%. If it's an electrical injury, don't touch them. Make sure that that electricity is shut off, that there's no electrical source going through them. And sometimes it's painful because we have to wait until that electricity is shut off from qualified personnel. Then we can remove the patient from the contact with the source. Chemical injuries, remove the clothing. Please, please, please be careful of yourself. Use the proper PPE for yourself. Brush those solid particles off the skin before you copiously flush with large amounts of water. Again, small thermal burns that we come in contact with, generally less than 20%, we cover it with clean, cool tap water, dampened towel just to the burn. Usually adults, when it's children, we want to be a little bit more cautious with that. Large thermal burns, ABCs. It always starts with the ABCs. We don't immerse them in cool water or pack with ice. Anyone know why? Any guesses why? Probably a good thing. Educated guesses why. Shock? Yeah, Sierra, that's a good one. What happens when we put really, really cold water and ice? What does that do to the vasculature? Does it dilate it or constrict it? Yeah, it's going to constrict it. That's going to lead to differences in fluid shifts. It's going to differences in blood and oxygenation, decreased blood flow. That's exactly it. And lastly, we can take that person, and if we douse them in really cold water and it's a very large burn, they run the risk of being hypothermic. Remember, that skin is thermoregulatory. We've lost that. So now they can't maintain that thermal regulation, so they're dependent on us to kind of help with that. So it's multi reasons why for that. But we just put them in clean, dry sheet or blanket. We remove burned clothing, but only if it's not sticking to the skin. You don't want to peel their skin off with it. This is a huge one. Remove jewelry if possible. Early intervention here. This is like the early intubation if we're worried about airway. So they are going to swell. They are going to become very edematous. And if we don't remove the jewelry early, it can cause the risk of losing digits. It can completely shut down blood flow to that digit or a wrist or a hand if it's a bracelet. And then there's the emotional level of it too, is that the only way to get it off at that point is to cut it, and you're causing some destruction. And if that patient doesn't make it, we try to preserve as much as we can for the family and the dignity. But the main reason is it can cause an injury if we don't remove it. Ocular burns, copious irrigation. If the eyelids are burned, we can give some cool compresses. And emergency department, pain and infection management, we can check the pressures in the eye with a tonometer, and they need to follow up with an ophthalmologist. I mean, that's definitely specialized care. So let's talk about some of the complications. I want you to look at this picture. In that picture, remember that earlier picture I said, the guy with the burnt face, they kind of have a tongue depressor in his mouth looking at it. That patient there could turn into this patient in a matter of minutes. Do you think you'd be able to intubate this patient now? No. This patient's going to require either tracheostomy or cricothyrotomy. There's no way you're going to be able to intubate this patient. That's why when there's the slightest hint of an airway issue, we aggressively and early take over their airway, because they can go from that prior picture to this picture literally in a matter of minutes. So complications we see in the cardiovascular are dysrhythmias, and that's for a couple of different reasons. One, if it's electrical in nature, but two, we're going to have some electrolyte shifts. Impaired microcirculation, increased viscosity, it leads to sludging in circulation. So we have the risk of clot formation. Hypovolemia and decreased cardiac output. The respiratory-wise, airway management, early and aggressive if we consider facial injuries or airway injuries. Give them humidified air and 100% oxygen. We check their ABGs, we check their carboxyhemoglobin level, and we get chest x-rays. The respiratory system, again, upper respiratory tract injuries, they cause edema formation. This picture is a classic sign of that. Mechanical airway obstruction and asphyxia. If this guy wasn't intubated early, he's going to have real problems. He's not going to move any air. The inhalation injuries, direct insult to the alveolar level. So interstitial edemas there, and they may not exhibit signs initially. It may kind of manifest 24 hours later. And then it can get subject to pneumonias, pulmonary edema, and ARDS. So the pathophysiology, moving down, when you think about it, look at that thing on the right. So you get a burn. That increases vascular permeability. Remember, the skin is a tissue, and it responds physiologically and pathophysiologically like that. You have an injury to it. A burn is an injury. Just as if you twist your ankle, your body does the same thing. That innate immune system goes. It increases the vascular permeability, which causes edema because it's getting white blood cells and macrophages in there and everything to infiltrate that area. You roll your ankle, it swells. You burn your skin a great deal, it swells for the same reason. That vascular permeability causes edema. It also drops your intravascular volume. That leads to an increase in hematocrit. That increases the viscosity of the blood, and that increases peripheral resistance. That edema is the same thing. It drops your circulating blood volume, which increases peripheral resistance, and that's what leads to the ultimate shocky state of these burn patients. They become hypovolemic through two different pathways, and they get hyperviscotic. So again, hypovolemic shock, colloidal osmotic pressure decreases, you get more fluid shifting out of the vascular space into the interstitial spaces. We call it third spacing. The net result of the fluid shift is intravascular volume depletion. So that, again, very, very edematous. They get a low blood pressure, and of course our body responds by increasing the heart rate. We get tachycardic. When we look at the fluid shifts, that elevated hematocrit, again, that creates the increased viscosity. They get hyponatremic. Well, all this extracellular sodium is depleted following changes in cellular permeability. So sodium shifts to the interstitial spaces and it remains until the edema formation ceases. And remember, sodium's a sponge. Where it goes, fluid goes, and that further contributes to the edema. Initially, they get very hyperkalemic. Why? Well, you get a ton of cells that are destroyed, and that causes hemolyzation of the red blood cells. So all of this releases potassium into the extracellular spaces. So what do we worry about with hyperkalemia? Does anyone remember, what organ do we worry about when we have hyperkalemia? What do we watch? Yeah, heart. Excellent. Yeah, arrhythmias, dysrhythmias, but the heart is what we look for in effects with that. Red blood cells are hemolyzed by circulating factors. Again, you get thrombosis. inflammation of the immune system. So burn injuries causes this widespread impairment of the immune system. The skin barrier is destroyed. That's your initial protection. You get a decrease in circulating levels of immunoglobulins, and you get increase in white blood cells and neutrophils, but then it drops rapidly. And you get a thing called a left shift as the immune system is unable to sustain defenses. Think of this as a mass casualty incident. Think of this as that Austin Music Festival. You only have so many ambulances, and then you kind of have to recruit pickup trucks. And that's what happens in a left shift. All these white blood cells are produced and used, and then the neutrophils and monocytes accumulate at the site of the injury. The left shift is when you get all these young, immature white blood cells. They're not quite ready to fight infection yet, but they're released. So you get a whole bunch of them out there, and that's what's called the left shift. Fibroblast and collagen fibrils begin wound repair within the first 6 to 12 hours of the injury. So let's talk about some of the clinical manifestations that we have going on here. You get shock from pain and hypovolemia, the blister formation. They may have adynamic ileus. That's a paralytic ileus. You get hypomotility of the GI tract. So we keep them NPO. Most of them get an NG tube or an OG tube if they're intubated. They're going to be shivering because they've lost that thermoregulatory function of the skin. They may have altered mental status. That altered mental status may be from the hypovolemia, causing some tissue hypoxia in the brain. They might just be hypoxic from carbon monoxide poisoning or smoke inhalation. Those GI effects are actually pretty specific with burn patients. Usually if they have 20% burns or more, you get a decrease in peristalsis and gastric distension. So they get an increased risk of aspiration. That's one. Two, the paralytic ileus due to secondary burn trauma, and that can lead to constipation. That can lead to impaction. Three, they get these stress ulcers. They're actually very specific. They're called Curling's ulcers. And we look for that. We look for melena, black stools, or hematemesis, or blood coming out of the OG or NG tube, which is indicative of duodenal erosion. Gastric distension, nausea may lead to vomiting. That decreased peristalsis, we spoke about that. So we keep them NPO. And if you want to learn more about Curling's ulcers, the history of it, who founded it, there's a link here that goes in depth with those. Let's talk about the emergent phase complications of the urinary system. Again, decreased blood flow to the kidneys causes renal ischemia. This is a pre-renal problem. Remember, pre-renal is about perfusion to the kidneys. Acute tubular necrosis follows, and they get a secondary acute renal failure can develop if it's not aggressively treated. And just to refresh your memory, what is the normal urine output? Well, what we use is about 0.5 milliliter per kilogram per hour. That's a pretty standard one. So when we assess for adequate fluid resuscitation, we monitor the mental status, vital signs, peripheral perfusion, body weight, labs, and urine output. Again, how are they mentating? Are they still tachycardic? Has their heart rate come down? Does their blood pressure come up? Is that peripheral perfusion? Are they pink? Are they have a delayed capillary refill? Or is it kind of coming back to normal? Is their body weight? Are they losing weight? Are they diuresing? Labs, is their hematocrit and hemoglobin all normalizing, BUN and creatinine? And let's look at their electrolytes. And of course, the urine output. The single best indicator of adequate perfusion and fluid resuscitation is urine output. We want to see about 30 to 50 an hour. That urine is a phenomenal indicator for these patients. And I know we treat it as nurses as just another bodily fluid, but that urine output can tell you so much about your patient. We expect these patients to get about a 15 to 20% weight gain in the first 72 hours. It's anticipated. Fluid should be titrated to ensure an output of about 30 to 50 an hour, 0.5 per key per hour for those patients. The most common reason for a urine output below 30 is insufficient fluid replacement. We're under resuscitating. So, or we calculated the fluid requirements, but we didn't take into account the time of the injury. So we're given, fluid that first half over 8 hours of the time we saw them versus of when that injury happened. We look for the urine for color, presence of blood. And if we have blood, we notify the clinician immediately, that care provider, because hematuria is common with electrical burns, so we know that, or deep tissue burns. It's an indicator of myoglobinuria and hemoglobinuria, and that destroys the kidneys, and that can lead to real problems. And these patients need to have higher volumes of fluid to dilute that out so it doesn't lead to acute tubular necrosis and acute renal failure. And that brings us to our magic Parkland formula of the day. It's the fluid therapy. So we want to get a couple of lines in them. One, preferably 2 large bore IV. And the fluid, what type do we give them? Well, it depends on the size and depth of the burn, but most of the time they're going to start off with, lactated Ringer solution. And then we go into our Parkland formula. And again, we scratched upon this with our assignment. So the formula, we're going to use is the one here. The one in the book is a little bit different, and actually the Parkland formula in general has changed over the last couple of years. And a lot of times courses like this, it takes a little bit of time to catch up with the cutting edge therapies, but we're going to talk about it this way. So it's the total BSA times the weight in kilograms times 4. And all that fluid goes in the first 24 hours. You split it in half. The first half of that fluid goes over 8 hours, and then the second is over the next 16 hours. And the start time is when the injury occurred. So let's look at it here. You got a 24-year-old in a car accident, 70% burns, and that's significant. They weigh 165 pounds. So here's our Parkland formula, 4 times the weight in keys times the BSA, which is 4 times 75 times 70. So this patient is going to get 21,000 milliliters of fluid in the first 24 hours. So we cut that in half. In the first 8 hours, they're going to get 10,500. So we do that. We divide it by 8. It's 13.13 an hour, rounding up. And then the second half goes over the next 16 hours. So that's how we're calculating our rate. I would encourage all of you to practice these types of questions. And I'm going to tell you right off the bat, most questions when it comes to burns and figuring out Parkland formula is not like this. What it's going to say is you have a 25-year-old involved in a car accident who has a burn to the anterior left arm, the entire right leg, the entire trunk, the front half, the face. So you're going to have to calculate it out, the BSA, with a rule of nines. And then you're going to have to change their weight from pounds to kilograms. And then you're going to have to remember the formula. And you just plug in those numbers. And then you can start that. Then split it in half. And they may say, you've seen the patient, hour 3 from the injury. That's when you're starting the fluids. So you have to take that into account of administering those fluids. Clear as mud? It just takes practice with this, and I can assure you it becomes second, if not first nature to you if you're dealing with burn patients. All right, here's a scenario here. 43-year-old male involved in a gasoline-related factory explosion. This is a classic question you're going to get. So burns to his face, that's 4.5%. Anterior trunk, that's 18%. Anterior left and right arms, that's 4.5% each, so that's 9%. And he weighs 187 pounds. What's the BSA using the rule of nines? We'll calculate that up. And then what do we do for his fluid? Again, this is a great question. So here, let's pick it apart. 4.5, 18, 4.5, 4.5. So 31.5% times 4 times 85 keys. And again, we took his weight in pounds, divided it by 2.2, and that's how we got 10,710 mLs. We split that in half. The first half, 53.55, goes in over the first 8 hours. And then the second half goes in over the next 16 hours. And that's your equation for it. And again, they say same scenario, but you don't see them until 2 hours after the injury. So now you don't have 8 hours to put that 51.55 or 53.55 in. You have 6 hours to put it in. Make sense? All right, cool. What time is it? It is 1:55. 15-minute break.
A quick question. You did burns to his face 4.5%. Did you do that because it said just the face, not face and neck?
100%, because the whole head, front and back, is 9%. So we're just saying half of that, 4.5%. Does that make sense?
When it says burns to face and neck, that'll be the 9%. So if it just says burns to neck, it'll be 4.5, right?
No, I think, let me pull up that rule of nines. The neck would be not involved in this. When I say face, 9%, that involves the face, the top of the head, the back of the head, the sides of the head. You see what I mean?
If it were the whole head, then it'd just say burns, sustained burns to head, not sustained burns to face?
Correct.
Right? Okay, got it.
Correct. Yep. Yeah, it gets a little wordy there, and that's where it can be a tad bit confusing. So, but yeah.
Okay. So the entire head is 9%?
That's correct.
Okay.
That's the face, ears, cheeks, back of the head, top of the head.
Okay.
All right. Well, let's come back at 2:15. We'll take a quick break and, get something to drink, shake it off, and we'll come back, and I promise you it goes pretty quick from here on out.
I have a question.
Yes, ma'am.
With the first scenario we did,
All right. Welcome back, everyone. Hopefully you had a little stretch, got something to drink, getting ready for the downhill run of the burns. So let's talk about the nursing and collaborative management in the emergent phase for these patients. So obviously wound care comes to mind when we talk about that, and it should be delayed until the patient's airway is stabilized, they have adequate circulation, adequate fluid volume replacement has been established. This doesn't take initial priority. We dress the wound, we keep it dry, we try sterile dressings, we want to minimize the risk for infection, but it should be delayed until we take care of the critical factors first. They may develop need escharotomies. So if the eschar, that really thick burnt area on top for these full thickness burns, is constricting perfusion or respirations, an incision through the burn eschar relieves the pressure. I have a case I took care of a patient who was in Las Vegas. He was driving a pickup truck. He hit a telephone pole and the car caught on fire. So he had circumferential burns to his chest. I was working in the emergency department that day. We didn't fly him in, and he came in. So I intubated the patient, and we tried to ventilate him, and squeezing that ambu bag was almost impossible. There was no air movement, no chest wall movement. So the physician and I, each side, took a scalpel and we did an escharotomy up to the lateral aspects of his chest and around into the center, up through the xiphoid, and immediately was able to ventilate the patient. So that's where an emergent escharotomy comes into play. I do have a video I want to show you on that. There's a couple of videos I have to show you this week. They're short, but I think they're pretty poignant and they underscore what that is. And the first one is what an actual escharotomy is. So it's a quick video and show you. Again, he's making an incision through, if you can see that burn part there, that's the eschar. There's no bleeding through that. It's really crunchy. And as he goes a little bit lower down, he's going to start doing a fasciotomy. So that's where it's a little bit deeper into the fat tissue. And you can see that scalpel running along there. And you may see a little bit of bleeding in that particular area. But the difference between an escharotomy and a fasciotomy is an escharotomy, you're cutting through that crunchy, thick eschar, or the fasciotomy, you're going through the fascia underlying. It's a little bit deeper, so there still may be some problems with that patient. They're having constricted blood flow still. So I'll show you that one. We'll get back to our PowerPoint here. All right, so that's the escharotomy. And again, a fasciotomy is if the escharotomy just doesn't relieve the pressure, they go a little bit deeper through the fascia and then relieve that pressure a little bit deeper down. Again, talking about that emergent phase and the collaborative care that we have, it's wound care comes into mind. Again, when open burn wounds are exposed, the staff should be cognizant of the infection potential. So they should wear disposable hats, masks, gowns, and gloves. Again, we want to prevent that secondary infection for these patients and advocate for them. Again, nursing and collaborative management, eye care for corneal burns. Antibiotic ointments are used. Periorbital edema may frighten the patient, so we can give them some compresses to hopefully minimize that. Hands and arms should be elevated on pillows or slings. Again, we want to minimize the edema. And ears should be kept free of pressure. So we don't use pillows usually. The perineum must be kept clean and dry as possible. Again, that is really a vector for infection in that perineal area if it's moist, and particularly with any fecal matter, so we keep them nice and clean. And we do routine lab tests. We want to look at the CBCs, look at the electrolytes, kind of keep an eye on what's going to help that patient heal in the wound care. And early range of motion exercises. That's one of the key things. We want to preserve function. And the way we can preserve function is early ambulation and early range of motion exercises. And of course, with all of that comes pain. So how do we treat these patients? We use drug therapy. Okay, we can use analgesics and sedatives. Morphine's a big one. Morphine is a very potent narcotic, although we do have other ones available on the market that have less side effects, like fentanyl. Dilaudid's another one. We can do combination therapy with some Haldol, lorazepam, and midazolam. So Versed and Ativan, again, sedatives and pain control are common for these patients. And tetanus immunization. We often joke in the trauma center that, sure, we're taking care of everything, but do we give them the life-saving tetanus? Everyone gives the tetanus shot, most likely. They get one. All burn patients, they want to be prophylactic in that nature. We also have antimicrobial agents that we can use for these patients. Those are some topical agents like silver sulfadiazine or Silvadine. We don't give it to patients with a sulfa allergy. Remember, it's a sulfonamide, sulfadine, silver sulfadiazine. Menifide acetate or sulfamylin. And then we can give systemic agents are not usually the first thing we go for, just because we don't have a predictability with the vasculature if that's going to actually take care of that patient for controlling burn flora on top. Usually topical agents better. But if they do have signs and symptoms of invasive wound sepsis, that's where we give them the hardcore IV antibiotics. Nutrition therapy is very important for these patients. And again, that's part of the assignment this week. Okay, fluid replacement takes priority over the nutritional needs, but once we get that fluid replacement, we want to be early and aggressive with nutritional support. Within hours of burn injury, it decreases the mortality, it decreases the complications, and it optimizes wound healing. They have to be nutritionally sound to have optimal wound healing. So we minimize the negative effects. They also have this hypermetabolic state going on. Don't forget that resting metabolic state increases by 50 to 100% above normal. So the core temperature is elevated, their caloric needs increase, and they're about 5,000 calories a day. So we have to account for that. Early continuous enteral feeding promotes optimal conditions for wound healing. And if you can't do it enterally, we can give them parenteral or supplementations. Supplemental vitamins and iron may be given also. Again, we really need to support these patients nutritionally. We do have dietitians that come in and help with burn patients, particularly the severely burned. Let's talk again about that escharotomy a little more depth here. It's the full thickness burns. It contains that eschar. That picture in the lower right is a very, very good picture of what that thick eschar is. It's tough. It's leathery. It may constrict the extremity. It may cause compartment syndrome. And following a full thickness burn, those underlying tissues rehydrate and constrict, and it leads to impaired circulation distal to the wound. And that escharotomy is performed just to kind of make the incision through that tough eschar, expose the fatty tissue, and kind of relieve that pressure. And the incision will often widen substantially. And again, you can see that on the bottom right. That is a very typical chest eschar. It widens by several inches in that one. So now that we've got that emergent phase, that resuscitative phase, we move on to the acute phase. And that acute phase begins at the end of the emergent phase. So it's about 36 to 48 hours after the injury when the fluid shifts have resolved. It only lasts until the wound closure is complete. So the nursing care of these patients includes continuous respiratory and cardiac assessments, GI and nutritional assessments and interventions, and wound care, burn wound care, pain control, and psychosocial interventions. Again, pain control is a huge one. And then psychosocially, they're starting to come into awareness and that this is going to be a lifelong injury that they're going to have even when it's healed up. So during this time, wounds are not completely healed, and infection's always a really, really big concern. So we want to promote those sterile or clean environments and minimize that risk for infection for these patients. In the pathophysiology, there's a diuresis that happens. So the fluid, that mobilization occurs, the patient is no longer grossly edematous. It's kind of getting back into a normal state. The bowel sounds start to return, and they start healing. And it begins when those white blood cells surround the burn wound, and you get phagocytosis that occurs. The necrotic tissue begins to slough off, and they get the formation of that nice granulation tissue. Remember, a partial thickness burn wound will heal from the edges. Full thickness burns must be covered by skin grafts. So complications that we can have in this acute phase are in the neurologic systems. There's usually not problems unless we have kind of prolonged hypoxia that occurs. They can be disoriented, combative, hallucinations, delirium, and they can fall subject to ICU psychosis syndrome. It's a real thing, particularly if they're getting a lot of analgesics or sedatives throughout their therapy. They become very disoriented, and they can become very combative, very hallucinative. And these symptoms can last from weeks, sometimes months after discharge from the intensive care unit. So it is a very, very real thing that these patients undergo. Musculoskeletal-wise, they get a decreased range of motion. They can get contractures. Their GI system, they can get that paralytic ileus, which can lead to impaction. The Curling's ulcer, remember that acute gastric erosion resulting from severe burns is you get this reduced plasma volume, and it leads to ischemia and cell necrosis and that sloughing of the gastric mucosa. It's very specific to burn patients. So we assess the stool for bleeding, or if they have an NG tube, at this point, that NG tube is most likely removed. Endocrinologically, they increase their blood glucose levels, they get an increased insulin production, but the ultimate thing is they get hyperglycemic. And again, when they're hyperglycemic, that inhibits adequate healing of wounds and adequate healing overall for these patients. So glycemic control is something that the nurses, that we as nurses, can really be on top of. Potassium. Again, we talked about that initial hyperkalemia, then you get a profound hypokalemia. And that's caused simply by lengthy hydrotherapy. We're giving them a lot of IV fluids. They have vomiting and diarrhea. And if they have a gastric tube in, a prolonged suctioning in combination and in concert with IV therapy without supplementation can cause that hypokalemia. And again, whenever we talk about potassium derangements, high or low, we worry about cardiac manifestations. So talk about cleaning and debridement. And that is a big, big part of these burn patients' lives in this acute phase. They remove exudate and necrotic tissue. So it cleans the area, the application of water for treatment. They have special shower tables or washing only small areas of the wound at the bedside. We don't really put them in tubs anymore. It increases the risk of infection. They try to promote natural healing or grafting, apply dressings, and then debridement for the burns mechanically. Enzymatically, they can do it over time. There's these chemicals that liquefy this necrotic tissue, and it may be done in the operating room. The purpose is to stimulate that granulation and revascularization of that tissue. So we prepare wound for grafting and wound closure by a natural process. Surgical techniques and consideration to remove this eschar, that really, really thick. I'm going to show this little video here. I will warn you, this is very graphic, but I think it's important for you to understand what these patients are actually going to be going through in this. So again, there's no audio to this, but I want to show you, these are some of the techniques with superficial or thicker, darker eschars. They're cleaning the area. They're going to prep it. They really want to minimize that risk of infection. That's huge. And this patient, you see that's all that thick eschar, and it's almost draconian in nature. It's the barbarity of how they remove that eschar from these patients. But as nurses caring for these patients, we need to understand what's going on because this patient is going to be in significant amount of pain. That's why it's done in the OR. But that wound is going to be abrasive for a long, long time. They may operatively cauterize and remove thick layers of eschar. And depending on where the issue is, where that burn happens, will relegate the size. I think I speak for Saul and I say we've seen enough of this right now. But I think it's really, really important that you understand what these poor burn patients must go through. And we appreciate that, and we can intervene with that, anticipate that. So tangential incision, tangential, and that's what that is, that tangential excision there. Okay. All right, so let's talk about grafts and dressings for these patients here. So there we go, sorry. Standard wound dressings, typical, sterile dressing. You may have biologic dressings. That's an autograft. That's where they use from themselves. They have a piece of skin maybe from the thigh, and they graft it onto the burned area. They can do allografts or homografts. That's human skin. Again, human tissue donation. This is a big part of it. When we spoke about brain death a few modules ago, this is one thing that we can harvest. They can harvest skin for this grafting for these patients. Xenografts and heterografts are skin from other species, usually pig, porcine in nature. We can do amniotic membranes, cultured skin. That's a small specimen of epidermal skin cells and that are unburned area. We grow them in the lab, and it produces a cell sheet. It's fragile, it's really, really expensive, so it's usually not the first go-to, but it's there. We have artificial skin. You can do 2-layer. It's a celastic epidermis and a porous dermis, so it's made of beef collagen and shark cartilage, actually, and it creates a new dermis, and then an autograft is applied to that for that outer layer. We have biosynthetic dressings. That's a combination of biosynthetic and synthetic. So they're for superficial partial thickness burns. So covering for meshed autografts and donor site dressings. You have this nylon fabric partially embedded into a silicone film, and it adheres to the wound, and it epithelializes. And then it's porous, so it allows all this exudate to pass through it. Synthetic dressings, which are that's silicone and plastic membranes. They apply them to the wound. They kind of remain there until they just fall off naturally. They're also used to cover donor sites from autografting. There's a video here. If you want to watch it, I would encourage you to. It's this gentleman's view of his own grafting procedure. So he talks about his wound and his first-person stance on it and how he went through it. So I'll leave that there for you to, it's in the PowerPoint, it's uploaded, to kind of watch that at your own time. Donor site on the top is after harvesting. You can imagine that is going to be profoundly painful. That's why they keep it covered. Again, the air will be very painful with it. It's almost creating a pseudo blister. And on the bottom, you see healed split thickness sheepskin grafting. Again, anatomically and maybe color-wise, it looks a little bit differently, but the whole goal is to restore function. I mean, that hand will not be used at all without these grafts. Deep burns cannot heal without the grafts. They may be temporary or permanent. So let's talk about some of the dressings. Multiple dressing changes for these patients. Sterilized gauze dressings are laid over a topical antibiotic. The dressings may be changed from 1 to 3 times every 12 hours to once every 3 days. In the acute phase, in some of these burns patients, if you're working in a burn unit, it is a very, very busy environment that you're working in. And you need to be cognizant that, don't forget, if these patients are getting these dressing changes, you need to anticipate that they're uncomfortable, A. B, we should time them appropriately and maybe be able to do other interventions while they're getting these dressing changes done, like range of motion exercises. So the purpose of dressings: 1, it prevents infection. 2, it facilitates healing. 3, it diminishes pain. And it limits the care load. Avoid limitation of movement and wound care. So we do daily observations, we assess them, cleaning, debridement, and dressing reapplication. So when you look at that picture to the right, what's wrong with that picture? Anybody notice anything wrong with it? Or is it completely normal? What do you think? 2 nurses taking a look at obviously a facial injury and getting some vital signs. Anyone?
Nobody's wearing gloves.
Absolutely. Masks, hat, general clean environment. You know, it's so, I don't know what the context of this picture is. I don't know the exact year, but this kind of all plays into how burn patients have increased their survivability over the years through learning not to do stuff like this. So good job. Okay, complications, infections, always a concern. It can be localized inflammation, induration, and suppuration. Partial thickness burns can become full thickness burns when they're infected, so they can actually get worse. Wound infection may progress to be transient bacteremia, and that's scary. They become septic, and the patient may develop sepsis and maybe fatal sepsis. So the top picture here is a burn injury with cellulitis. It increases in erythema, swelling, pain, and the uninjured skin around the periphery of the wound. You can see how excoriated that looks. The bottom one is a very invasive burn wound infection. So there's bacteria or fungi that are proliferating in the burn eschar, invading underlying viable tissue, and the wounds are really discolored. They have new drainage. It's very, very foul odor, and it will most likely lead to a life-threatening systemic infection. So what do we do nursing-wise and collaborative? Pain management, that's a huge one. Patients experience 2 kinds of pains. There's that continuous background pain, and then there's treatment-induced pain. You saw some of the treatments they do, all the debridements, the wound dressing changes are all painful procedures on top of the underlying pain. So we can do several drugs in combination, morphine and Haldol. Treatment to induce pain managed with potent short-acting analgesics. You know, the thing we also need to be cognizant of is that we're giving them a lot of narcotics, so we need to watch respiratory rate and function. We need to monitor them so they don't become impacted from paralytic ileus. And then there's addiction considerations on the end. So we can also introduce non-pharmacological therapies, relaxation tapes, visualization, guided imagery, biofeedback, and meditation are all concurrent concomitant therapies we can do with these patients. In the acute phase, again, we limit the visitors in the room when they're immunocompromised. We don't want to introduce that infection. So we avoid raw foods for that matter. We make sure they have a nice high-calorie, high-protein foods and supplemental feedings. Physical and occupational therapy are going to be very, very key. So we need to find a good time for exercise is during wound cleaning. Like I said, we're kind of bundling some of this. Passive and active range of motion. Splints should be custom fitted and ambulate 2 or 3 times a day and progress in length each time. Remember, early ambulation preserves function for one, but it's also going to prevent clot formation, deep vein thrombosis. We're preventing that thrombovenous embolisms. Psychosocial care is going to be huge, so we need to have that psychosocial support, social worker involvement, nursing staff. We're going to be there every day, and pastoral care if they request it. So we need to be very attentive to that for these patients. And that segues into our final phase, which is the rehabilitative phase. That begins when the wound is closed, and it ends when the patient returns to the highest possible level of functioning. So pathophysiologic changes we expect, the burn wound heals either alone or with grafting, and the layers of epithelialization begin rebuilding that tissue and structure. You get collagen fibers that add strength to those weakened areas, and a mature healing is reached 6 months, sometimes up to a couple of years it takes. The skin never really completely regains its normal color, original color. Discolorization of the scar fades with time. We do know that, and pressure can help keep the scar flat. Newly healed areas can be hypersensitive or hyposensitive to heat, cold, and touch. So we need to be cognizant of that and educate our patients that watch for any secondary infection or secondary traumas that you can have. You can injure themselves in that skin because they don't feel it, that it's hot or cold. So we just need to kind of help them with that. Healed areas must be protected from direct sunlight for a year. And then complications, skin and joint contractures can happen. The most common complications during rehab phase, and you can see that in the upper picture there, where extremity may become limited in range of motion because of that contracture. On the bottom are those hypertrophic scarring, and they can have pain with range of motion exercises. They will have pain with range of motion exercises. So we need to consider pain management. However, they need to complete the exercises. And again, we need to be working with them and acknowledge their concern regarding the pain, but also discuss how it promotes a healthy lifestyle after that. This plan is a way to have less pain going forward, but better ambulation and better movement to let these therapies happen. They need just a better quality of life, and that's what they're there to improve that. So the rehabilitation needs change throughout various stages of the recovery. When it's an acute rehabilitation, that includes elevation of the extremities, reducing swelling. We want to prevent pressure ulcers and anti-contracture devices and splinting, stretching, range of motion, and early mobilization. The primary goal is to maintain or achieve normal range of motion. That's the ideal. In the long-term rehabilitation phase, that's composed of a real structured exercise program, aerobic, resistance training. So we want to increase function, increase muscle mass, strength. We want to make sure that cardiovascularly and respiratorily that they're improving. Coordination and balance is better. And it's described that independent ambulation is an important predictor for the patient's discharge from an acute burn center. So it's really important that they work hard and we help them push through those episodes to get through that long-term rehabilitation to ultimately get better. And of course, as much as we have to attend to the patient, we need to attend to ourselves and we need to attend to our fellow nurses. So the nurse who cares for these patients, at times the patients are unpleasant, they're hostile, they're apprehensive, they're frustrated, they're scared, you name it. And the nurses are there and we're the sounding board for that. So nurses who are new to burn care often find it difficult to cope in the beginning. Actually, any specialty that they go into. There's going to be times where you need to self-help and seek the help of others. This is where we need to look out for each other as nurses. And those who are in my clinical, we discuss this. It's about helping each other to prevent that burnout that can so often happen in our profession and how we can deal with it effectively. There's been a lot of advances in burn care. So research in inflammation, infection, stem cell grafting, biomarkers, inflammation control. There's been a whole bunch of advancements, and that's what this link is to. The link is to a paper. I would encourage you to read it at your leisure, and I say that affectionately because you're nursing students. You don't have leisure time. But I would really encourage you because it really gets into the nuances of the advancements, particularly if burn care nursing is something that you're interested in or passionate about. Some of the other things we learned about, I love these new therapies that come on. So again, fluid resuscitation, the hallmark of burn care for the last 50 years. It's all about adequate renal blood flow. But we have dangers. We can overhydrate them. And the dangers for that can be abdominal compartment syndrome. We can have so much in that abdominal compartment that it causes necrosis in there, with loss of upper airway control, extremity compartment syndrome, pulmonary edema. So we found out that if we give some of these patients high doses of vitamin C during the first 24 hours of that burn resuscitation, they don't need as much intravenous fluid for that adequate renal perfusion and that hemodynamic stability. So it's been a multiple animal studies. This has been done. So what happens is this high dose vitamin C is thought to decrease the post-burn microvascular protein and fluid leakage. And it's done so by reducing the lipid oxygenation caused by burn injury because that generates free radicals. So it's pretty impressive. So I encourage you to read this article. Again, if you're really passionate about burn care, these antioxidants, they've also translated into other parts of medicine, such as AFib and post-open hearts. So it's pretty neat to read some of that. The other thing is tilapia, and jokingly say it's just not for dinner anymore. This is a link to what they're doing to use tilapia skin to help with healing. So they wrap the patients in that and get profoundly good results with this. So all these neat different aspects of research are really coming to fruition for burn care. Again, going back in the 60s, you were fatal at a 50% burn. Now, because of all these advancements, is why these patients can survive. And you're right, Courtney, it really is awesome. Because who would have thought to do that, Just like in trauma care, leaching. We do leaching still. We got rid of that, but we found it really, really promotes blood flow. Yeah, it looks like a mermaid skin, Rachel. I agree with that. New Halloween costume. So I got a couple priority questions here. So you're just received change of shift report on a burn unit, and you want to see these patients, and I want you to prioritize your care. So patient A, deep partial thickness burns on both legs, complaining of severe and continuous leg pain. Patient B has just arrived from the ED with facial burns sustained in a house fire. Patient C has just been transported from post-anesthesia care unit after having skin grafts applied to the anterior chest. And D is a patient admitted 3 weeks ago, full thickness leg and buttock burns, who's been waiting for 3 hours to receive discharge teaching. Who are you going to see first? A, B, C, or D? B, 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 B. Excellent. Obviously, that's the one. Facial burns, that can be big red flags. That's going to need emergent interventions and maybe emergent intubation. So, okay, so that's a good one. Who are you going to see next? A, C, or D? Someone who just came back from the PACU, or someone with pain, severe and continuous in both legs? Or the admitted 3 weeks ago? I got a D, I got a C. All right. I agree with C. So C is the answer there. So you got someone that's just coming back. All right, Courtney, I got you. From the PACU, you need to assess them. What's their level of consciousness? Have they had any complications from that? Did the grafting take place? Is there any issues? Right. Okay. And then A, I see that up there. And obviously the one waiting 3 hours for discharge, they're not the priority. It is a priority to get them home, but those other patients. So good job, everyone. I like that. Thank you. Last thing I want to talk about is burn nursing in general. So there's a course you can take called Advanced Burn Life Support. I've taken this before. It's a certification to teach you care about the burn patient for the first 24 hours. It's valid for 4 years, and you can contact this link if you have more information on it, if it's something you're interested that you want to take. But what about care after 24 hours? Well, believe it or not, it hasn't been until 2020 that the American Nursing Association finally recognized burn nursing as a specialty. So you can actually take and get certified as a burn care nurse. And if you want more information on that, I would encourage you to click those links. And with that, ladies and gentlemen, we are done with Module 6. Burns, burns, burns. Any questions? How does everyone feel about that? Not too bad, right? Yeah, good. Okay, cool. And again, this has been recorded, so it'll be uploaded into Blackboard. Yeah, you know what? I think it's fun because it has pictures and tangibility. Some of it's not so abstract as some of the other disease states that we talk about. So this is relatable to everyone at one degree or another. I hope you found the pace okay. Again, I think it was a decent way to go about it. Let's see. Oh, good. Okay, cool. Any questions? Any questions about this or anything else this week with the assignment? If not, your day's done. Thank you all for the birthday wishes. I really, really do appreciate that. Yeah, thank you, Arthur. And I will enjoy the Lightning games. So I appreciate my wife for getting me those tickets so we can all go. And thank you all very much for your time and attention today. I know the afternoon sessions are always a little sleepy, and hopefully you enjoyed the lecture today. All right. Have a great week, everyone. Best of luck to you on any exams you have coming up, and feel free to reach out anytime. All right. Now I'm done.
Bye.
Take care.
You.
Bye. All right. No problem. You have a great day.
Thank you.
No problem.